So I'll tell you a little bit about me. My name is Sharon Ben-Haim. I'm an epilepsy surgeon at UC San Diego. I was trained at Yale, where we have a really exciting epilepsy center, and I'm here bringing kind of some of the new innovative techniques that haven't been around much in Southern California to Southern California, particularly to the San Diego area. And so some of the new and exciting stuff I wanted to talk about and really stress to everybody is that there are new interventions that just didn't exist a couple of years ago, up to even 5 years ago, that are now recently becoming available for patients with epilepsy, and that is something, really exciting options. So people who have been denied surgery in the past because they weren't candidates, or people who have been involved in invasive, maximally big surgery approaches now can be candidates for minimally invasive approaches. And so the two big interventions I wanted to talk about were laser ablation, which is a really new and exciting technology that we have that, again, wasn't around just a couple years ago, and also a technique called NeuroPace, which is a responsive neurostimulation system. And so what are you guys interested in?
Well, actually, I was interested more in VNS, and I wasn't sure if you were going to cover that or not.
I wasn't planning on covering it, but I certainly can.
But that's okay.
Yeah.
No.
Yeah. Yeah.
But yeah, that is because my daughter has generalized epilepsy.
Okay.
So, there's really not anything that's completely available. We talked to Caitlin Hoffman from the Cornell Center about some of the newer techniques doing in terms of the generalized, where they go to the ultrasound that they're now using for, I guess, essential tremor.
Are they using that for epilepsy?
They want to.
Yeah.
And so VNS is kind of one of our next steps.
Sure. Sure. Well, a couple of thoughts on that. High-intensity focused ultrasound is an amazing new tool. I think it will be the future of neurosurgery. For you maybe who hasn't heard about it, it's a system which is incisionless. So there's no incision. You don't have to make any actually perform a surgical procedure. You can't say it's not invasive, because it certainly is invasive, but it uses ultrasound waves that are all over in a radial fashion that all converge on one point in the brain that's localized with the MR scanner, and then uses all of that energy to create a small lesion or a big lesion, depending on what exactly you're treating, in the brain, all without an incision and in real time and in an MR scanner. And so it makes it quite precise and very effective. The problem is that we're all excited about this technology. The problem is it's just not there yet. So right now, ultrasound is FDA approved for essential tremor, because the way the ultrasound beams, the current algorithms allow them to be focused more in the center of the brain. So in areas like the thalamus, which is right in the center. For epilepsy, they're doing a trial now in the hypothalamus for hypothalamic hamartoma, is a very, very particular type of epilepsy, where you have a lesion in the hypothalamus, and that's again in the center of the brain. So all the beams can easily converge in that one location precisely. But when you're talking, for example, about the temporal lobe, we're not there yet.
What about frontal lobe?
Frontal lobe, I think we're not there yet. But I think we will be. And I would give it a couple of years before they can hone their algorithms, so that we can really get a lot more flexibility with the laterality of the actual treatment.
And then, just out of curiosity, because I know MRIs can be more complicated complicated when you do put a VNS in.
Uh-huh.
If you had to do that, just say you put a VNS in and then 5 years from now there is that ultrasound treatment.
Yeah.
But you have this thing in your neck, so
Right.
what's the complication?
So that's a great question, and I don't know the exact answer to that. So with a VNS system in place, you can only do an MRI with a send-receive coil. It's just a different coil for doing MRI. And so I know from a laser ablation perspective, because I've done procedures on patients who have VNS systems in place, you can do a laser ablation with in the MR scanner using the send-receive coil for a patient who has a VNS in place. But you can't use some of the systems that we currently use, for example, to localize placing the laser catheter in the brain, because they just currently aren't set up, for the send-receive coil. So there are some limitations, and for focus ultrasound specifically, I'm not sure what they will be.
So it's really hard to take that coil out.
It's very doable. It's very doable, but it's a procedure, that certainly you wouldn't want to undergo unless you had to. So, but as far as your question with focused ultrasound, if it's really a generalized epilepsy, the goal, of course, of any sort of ablative procedure is to find a lesion.
Which is the next question, which would be, is there any potential future applications for this generalized, obviously it's going to take the place of laser ablation. I think that's sort of what you're driving at. But for more generalized things, do you see this ultrasound application being used?
Not in its current form with high frequency. There are some research studies being done with low frequency ultrasound where the idea, and they're actually doing some of these at UCLA for the temporal lobe, where the idea is to modulate activity rather than to actually cause
like reset it, basically.
Right. And so that's really under investigation currently. So there hasn't really been anything definitive from that perspective. But certainly there's potential there. Yeah. So for those of you who just came in, we were having PowerPoint issues, and because we're an intimate group, we decided to turn this into a question and answer session. So one of the things we talked about initially is new and exciting treatments that are available now that weren't available 5 years ago for treating epilepsy, specifically things like minimally invasive options like laser ablation therapy, and also options like NeuroPace, which is a closed-loop neurostimulation system you might have heard of in the past. So if there's any questions, I could talk about those or answer any specific questions you might have. Yeah, nice to meet you. So I'll talk a little bit about the laser ablation because it's something that I'm really excited about. It's a procedure that requires us to have actually identified a seizure focus. It's a definitive procedure, meaning that the goal is to actually cure epilepsy, not just palliate it. We don't always achieve that, but because it's such a minimally invasive procedure, a lot of times if you have even a suspicion that you might have a focus, it's something that can be worth doing, particularly if the area of ablation is not in a particularly sensitive area of the brain where you don't expect to have any side effects. Again, so the way the procedure is done is pretty cool. Everything is done inside of an MR scanner. So the patient comes into the hospital. It isn't performed under general anesthesia, so you go to sleep completely. And then you go inside of the MR scanner where we've already identified the plan for ablation. We stereotactically place a 1.65 millimeter laser catheter into the area of interest, which is tiny, meaning we can do it, essentially it's almost like doing the procedure through a needle. Actually, the way we do it at UCSD, we don't even have to put in a stitch or use a knife. It's basically a needle-guided approach. We do have to get through the skull, so there's a tiny little burr hole that's made, and then we stereotactically place the laser. We know where the tip of the catheter is because we are in an MR scanner, and then we can see actually the ablation occur in real time by looking at what's called MR thermography, which is a new technology. It's recently become available, and it allows us to view heat on an MR scanner. So we can this allows us to very precisely localize the area to be ablated. And this has, in many ways, started to take over the areas where big open craniotomies, which we also perform, have been the only option in the past. You know, where you have to go into the hospital, it's a big incision, big craniotomy, and then a large resection of tissue. With the laser procedure, patients go home the next day. They stay in the ICU overnight for observation. Usually they wake up quite well, groggy from the anesthesia, but otherwise feeling great. We observe them overnight, and they go home, walking home the next day. So it's really exciting. Sometimes it doesn't work. That's probably the biggest risk, and that's okay. If it doesn't work, you can always do it again, or you can always opt for the bigger procedure if that becomes necessary. So it doesn't actually preclude you from any other treatments, which is one of the things that's exciting about it. So for a lot of my patients, I say that if I had the option to do laser ablation, even if I had the option to do that first just to see if it works, I would probably take that option. Again, it's not necessarily available for everybody. You have to have a specific type of epilepsy where you have a focus, and that focus is something you can ablate. But for the people where it is an option, it's an excellent option.
What procedures do you have for generalized?
Yeah, and that was the other question that we just talked about. It's very hard with generalized epilepsy. Of course, it depends on what kind of epilepsy and how it generalizes. But unfortunately, when we don't have a focus to treat, that really limits our options, and now we go towards the other side of surgical procedures, which we consider palliative procedures rather than definitive procedures. So the goal of a definitive procedure is to cure epilepsy. The goal of a palliative procedure is to reduce the number and type and duration of seizures, which is also quite a viable thing. So vagal nerve stimulation, of course, is a good option in some patients, although it's important, if being considered for vagal nerve stimulation, that the workup has been done, and you do know that this is, in fact, a generalized epilepsy. Sometimes generalized epilepsies can have a focus, and you just didn't know because the workup wasn't done. So, yeah. Any other questions?
I had my surgery done before this came out, so I was finding it interesting. I called my doctor right away, and I was like, wait a minute, why don't we do this? Because we couldn't have done that on you. I was like, okay.
Yeah. Yeah.
No, I don't feel that.
Yeah. But, it wasn't even around, even 2-3 years ago. It wasn't really an option. Oh, now we have a video. Nice. How did you make that happen? Oh, on your computer?
Yeah.
Well, I think at this point, we've covered a lot of the things. If you guys would like, is this one?
Oh, no, I'm sorry.
Yeah, that's it, I think.
Is that it?
Yeah. If you guys would like, I can show you a video, if it will play, now that we're on a different computer, of the laser procedure, so you have a sense.
So did you go through a special training, or did you have to go back to school or something?
For the laser procedure? Well, I did my fellowship training at Yale, where we actually had the laser procedure while I was a fellow. So that made it pretty easy because I was already pretty well versed in it. But
I have a young daughter who, on her career search, they put neurologist as one of her searches. Where do you recommend she look into stuff to do?
can you just play that video? Sorry, can you repeat that?
I have a young daughter who's on her career searches, neurologist camp. Where do you recommend she look to go to school for that?
To become a neurologist? Has she gone to medical school yet?
No, she's young.
Oh, she's young. I see. So where should she go to school? So it's such a long and very fun process, this medical career. So of course, the first step is go to a good college, as of course as good as you can get into, and it's not necessary to go to any specific college. some colleges have undergraduate programs that do combined undergraduate and medical school training, and those are great. Sometimes you can do medical school and undergrad in 6 years rather than 8 years. But after college, of course, then apply to medical school. And then in medical school, and around your 3rd year, that's when you sort of make that assertion of what you want to be. And so, at that time, she'll start rotating through neurology specialties, and then she'll do her residency in neurology. And there's a lot of excellent programs. You probably want to keep her here in Southern California. Yeah, but we have excellent programs here. All the UC system, has wonderful medical school training, wonderful, programs, and it's nice because as a California resident, the tuition is great. I actually went to UC San Diego myself, and so it was a great place to go to medical school. Yeah. Okay, thank you. Here we go. So this is the video, just so you get a sense. It would be sort of a small miracle if it plays. All right. So this is thank you. This is how the procedure is done. You didn't see the first part of the procedure where the laser catheter is actually placed, but the surgeon and the radiologists are in the radiology room as the patient's already in the MR scanner. The laser catheter has been placed, and here you can see what I was talking about, those maps of heat that you can see now on the MR machine, which is, again, it's a new and exciting advancement. Here you could see the laser catheter working and ablating the area of interest. And again, all of this is done through basically just a needle. And
How long is it in?
how long is the catheter in? Just for the procedure, so however long the procedure takes. For us, the procedure lasts roughly 3 hours, by the time from start to finish.
And somehow it'll tell you like, okay, you're done at this spot, and somehow.
Right, and so so it's actually quite precise the way it tells you that, because you can see the areas here in red and yellow and in green. They actually tell you relative temperature of the tissue, so you know exactly when the ablation's done because you know that you've gotten to the appropriate heat. Yeah, it's really exciting, really exciting new wave of technology that's revolutionized the way we treat epilepsy. There were lesions in the past that would have required a huge open surgical procedure that's just, wasn't worth it to put the patient through. It's too dangerous. And now we can target it with a needle.
But you can still have like post-op you can still like lose your vision or mobility or, right?
So vision loss specifically is a lot less with this. The one thing you do worry about is any damage that occurs to any area that you're ablating that might still be functional. Now, generally speaking, if you're ablating the area, for example, the medial temporal lobe, oftentimes it's no longer functional. But specifically in the dominant hemisphere, which is the left side for most patients, if you do ablate the hippocampus, you can have some problems with if the hippocampus is still functional, which again in a lot of patients it's not, then you can see some deficits, for example, in verbal memory. So those are the patients that we sometimes don't do this procedure on. Yeah, but whatever deficits you see are less than what you'd get with an open surgery, where you're resecting that tissue and usually tissue around it. So, yeah. The data is still really new with this. Long-term results are still just coming out. But so far, the short-term results are so good and patients are doing so well that it's very exciting to move forward. And even if patients recur, the actual risk and side effect profile is so beneficial that it's worth just doing the procedure again if necessary. So, yeah.
Now, expense-wise, does this cost more than cut you open kind of surgery to remove the scar?
That's a great question. The operating room is an expensive venue in general. And usually with an open temporal lobectomy, for example, you're looking at a hospital stay between 3 and 5 days. Whereas with this, you're only looking at a 1-day stay. So I think the math works out so that it's almost the same. Insurance companies, of course, pay for this, so I think for the patient who, assuming has insurance, usually it's not, it's no different. Yeah.
Yeah, I saw the doctor bill afterwards. I don't know, a couple years afterwards, I called them. I was like, what did this cost? It took about 9 hours. And they sent me the bill. It was crazy what they charged me for, but it was like 80 grand.
Wow. Did you have to actually pay for it?
Nope.
Okay, good.
Nope, not a dime. But
Excellent.
Gosh, I had no idea.
no, when I knew it was more than like your ankle or something.
It's an expensive enterprise, definitely. Yeah.
I think, well, they kind of like forgot about me. I did them either Monday or Tuesday, and then Friday came along and they left me there over the weekend. I was like, yes, I'm still here. I shouldn't be here, but.
Yeah. Well, good. Well, thank you guys for coming.